Hello everyone and welcome to the class. Today we are going to discuss about the orbit and its contents. So I will try to describe the orbit and its contents with the help of this animation as far as possible. So if you have got any doubts, then you should post me in the feedback about what are the things that you have doubts, so that I can discuss it more clearly in the next classes. Okay, so before going on to the class, I want to explain to you that I have got the skull, the view of the skull, and the view of the skull in one side, that is on the left side. I have left this left side complete cavity, orbital cavity empty, and on the right side I have filled up with the contents, so that we can go through the orbital cavity first, and then we will go through the contents of the cavity. Okay. So before going on to the orbit, just I want to tell you that if you have a look at the skull, then you will realize that the orbital cavity, it is occupying the upper part of the skull, and it is being bounded by certain bones. So but before that, I want to just tell you what is the generalized geometrical architecture of the orbit and its cavity. So for that, I will show you in an imaginary line about what the orbit will look like in this skull. So while viewing in through the geometry, we have to look at the orbit and its cavity from above. So for doing that, let us look at the orbital cavity arbitrarily from above. Okay. So what I will do is, just I am rotating the skull, and from behind I have just removed the occipital bone. I think you can align yourself, orient yourself to this skull in which the occipital bone has been removed. It is not much of a problem, right? So when we go from the back side and then we look at the skull from the above, then what we find is that if I just make the frontal bone a little bit faded, okay, so what I will see is that the orbital cavity, if you look, then the orbital cavity has got a medial wall. This one is the medial wall, and this one is the lateral wall. Okay. So the medial walls of both the cavities, if you see, this is the right cavity, this is the right side, right orbit, and this is the left orbit. Okay, left orbit. I think this is not much of a problem here to remember this thing. This is the medial wall. This is for both of them. This is the medial wall. This is the medial wall. Okay, and this one is the lateral wall. So this is the lateral wall. Lateral wall. So in both the sides, the medial wall are parallel to each other. So what are the things that I want to tell you is that medial wall of both the sides is parallel to each other, and the lateral wall, when I extrapolate the lateral wall of both the sides, then what I see is that the lateral wall of both the sides meet each other at an angle which is actually the 90 degrees. So lateral wall meet at 90 degrees. 90 degrees. Okay. So what I want to tell is that medial wall is parallel to each other at a distance of about 2.5 cm from each other, and the lateral wall is meet each other with the help of extrapolation, of course, and that too, when we extrapolate, then we see that the two lines are meeting each other at 90 degrees. Now one more thing I want to tell you is that if you look at the orbit from above, you will also realize that the orbital cavity has been guarded by the nasal bone. This is the nasal bone. Okay, you have got the nose, right? The nose is the most prominent area in this part. Okay, so the nasal bridge or the nasal bone is actually the most elevated part in the orbital margins. One of the margin, the medial margin, it will contain the bridge, right? The bridge is just in between the two sides. And of course, one more thing, you can see that this is the eyeball, right? This is the eyeball. On the right side I have included the eyeball. So eyeball is not protruding out from upside, from the above. When you try to see the eyeball, then you can't see it properly because it is covered by the frontal bone, and this is the supramarginal crest. Okay, supramarginal marginal crest of the frontal bone, which is actually covering the eyeball, and it does not allow the eyeball to be directly be in contact with anything, any flat surface when you are hitting against any flat surface. Okay, leaving about any any rough surface or any uneven surface. When you hit directly with your face down onto the floor, plain floor, then what happens is it is the eyeball is directly done, it does not come in contact with the surface, because one thing is that your nose, it is preventing it because it is the most elevated part you can see here, and the second thing is you have got a supramarginal crest margin, these two supraorbital margins, supraorbital, sorry, so it's not supramarginal, it is the supraorbital margin, supraorbital margin, supraorbital margin, which is preventing it from directly exposing into the frontal or directly coming with the contact of a flat surface. So this is in one way, actually this is the mechanism by which the orbit is being prevented from any kinds of direct injury from external objects. Leaving about the undulating surfaces or uneven surfaces, of course there is a chance, but this thing is a natural defense mechanism by virtue of its geometry or the structure itself. Okay, so now I am just going ahead from here. What I do is I again show the frontal bone, and just I try to move the entire thing from the lateral sides, so you get the view from the lateral sides. Okay, so from the lateral sides, if you look, then you will find that the orbit is actually protruding out. So just look at the diagram. If you see the lateral margins of the cavity, the lateral margins of the cavity are behind from the sides, this is the side view, this is the side view. So from the sides you can realize that the orbit is protruding out, the eyeball is protruding out. So basically what I mean to say that, of course from the above there is a elevated margin, there is a crest nasal bone here which is preventing it from directly coming in contact with the cell, with a plane surface, and preventing the orbit, the eyeball. But the eyeball has to have a very wide angle view. It cannot be put behind the bone so that you get a narrow angle of viewing. The camera has to be exposed to the outside. This is a camera. I am just synonymously using it as a camera. So the camera has to be exposed outside. So it is put behind the margin, especially towards the left. From the lateral margin, it is exposed outside. Okay. So while it is being protected, but the lateral margin is put a little bit behind, or the orbit is protruding out, you can say the eyeball is protruding out, so that it is getting a wider angle of view of the entire things which is present in front of it. Okay, so this is the beauty of the structure. Now moving ahead, we are here to study about the margins first. Okay, so if we go to study about the margins, then I am going to ask you that tell me what are the bones which are making up the margin. Okay, I mean what makes up the orbit. Okay, so when the question arises what makes up the orbit, you are going to tell me, sir, why are you asking such a simple question when the answer is just in front of you? Of course, when the model is not there, it is difficult, but when it is in front of you, the model is there in front of you, you can directly name the bones. Okay, let me name the bones. So while trying to name the bones, the thing is that this is called as the, yes, this is called as the frontal bone. This is called as the ethmoid bone. This is called as the maxilla. Anything else that you find out in the orbit? This entire thing is the maxilla. Okay. This entire thing is called as the ethmoid, and this upper part is called as the frontal bone, right? So this completely makes up the orbit. The bones of the orbit are, which make up the orbital cavity, are the frontal bone, the ethmoid bone, the maxilla. Yes, you are right, my dear. But the thing is that these things which make up the orbital cavity is not actually the orbital cavity in depth or the inside. What you see is actually the orbital margins. Orbital margin. Okay. So the orbital margin is made up of, which is very clear, the frontal bone, the margins of the frontal bone, the orbital margins of the frontal bone, sorry, it is not the ethmoid, I am sorry, I was thinking something else. This is the zygomatic bone. Sorry, you should correct it, no, when I am telling it. Okay, so this is the zygomatic bone, and this is the maxilla. If you cannot correct, if you have corrected me in your mind while watching the video, that means you are oriented in the class. If you cannot correct, if you go by my words, then you are not oriented. So take a break if you are not oriented. Okay. So going forwards, this is the frontal bone, the zygomatic bone, and the maxilla, which is actually making up the orbital margins. Okay. So going forwards, if we enlarge, or if we take a look at the different parts of the orbit, we will see different bones which are being involved. Okay. But before that, I want to tell you from upwards what we are going to see on the roof of the orbit. Going by the roof of the orbit, what we are going to see. Okay. So let's take a look from upwards. Again, coming back to the upside, I am just trying to make the frontal bone go faded. So this is the fading of the frontal bone. What we see is that this one, the orbit from the roof, you can directly realize that the bone which are made invisible will obviously make up the orbital roof, as you have already seen that in the orbital margin the superior bone was the frontal bone. But what you have to realize here is there is another bone which is present from the roof. I have to tell you, so I will start inking it as this part, this particular bone which is there, this one is the eyeball. Just have a look, this is the eyeball, right? So this eyeball, it is making up the orbital cavity, and also the extraocular muscles. These are the extraocular muscles. So you are in a common notion that the orbital cavity is this entire conical thing, right? So this entire conical thing, it is having a base. This one is the base of the orbit. This one is the apical part or the apex of the orbit, and that is why we have got, this one is actually a prismatic appearance. It has got 4 sides. So we are going to study about the roof of the orbit and the bones which make up the roof of the orbit. So from above we can clearly make out that without making the frontal bone go faded, you cannot see the orbit from above. So of course frontal bone is there, but there is another bone. This entire bone is the frontal bone because there is a shelf, the squamous plate. Squamous plate, that means the flat part of the frontal bone. Squamous plate, it is actually hiding the view from the superior view, that is the view from above. So if I just go into a little bit, if I just tilt it and I look it from the backwards, then what I find is, from this view, I have got another bone which is there in the middle, and this bone it is called as the sphenoid bone. So please this one is the ethmoid bone, and this one bone which is there on the posteriormost part, this is called as the sphenoid bone. So please take a closer look into the bones which are actually hiding from the view. Okay, when you are going to study about the margins of the orbit, you are going to tell me directly on my face that, sir, this is the frontal bone, this is the zygomatic bone, and this is the maxilla bone. Okay, I agree. But the thing is that when you are going to tell about the orbital cavity, you have got additional bones which you will want to cram it up. So before cramming it up, I just want to give a glance at what are the bones which are actually hidden in the orbital cavity and which will bother you about cramming it up, about the different bones which constitute the orbital cavity. So one bone is the ethmoid bone which is there in the middle, and the second bone is the sphenoid itself. The body of the sphenoid, this is the lesser wing of the sphenoid. I think you have studied the bone, the sphenoid. Okay, so this is the lesser wing of the sphenoid, and of course some part by the greater wing of the sphenoid also. This is greater wing. We will study, we will see now what makes up the greater wing and what part of the cavity is making up the lesser wing, and what part is some part of it is actually exposed to the body of the sphenoid bone also. Okay, and also I want to tell you that there is another bone which is present just in the midline. This is called as the palatine bone. Palatine bone. It is actually making up the palate, and a perpendicular projection is also there in the nasal septum. So some part of it is also coming as a constituent of the constituent bone making up the orbital cavity. So these are the things which I want you to just have a closer look. Please have a closer look from anterior part, from before backwards. I would say that there will be a palatine bone. There will be, of course, there is a bone which is there, which is lodging your nasolacrimal duct and the sac. So this is the nasal bone. Okay, so nasal crest is there. So in that bone will also come, yes, of course, the nasal bone, parts of the nasal bone also. Behind that there is a palatine bone which makes up the palate. This one, the hard palate. And from the hard palate there will be projections which will be going upwards to make up the septum, posterior part. That also some part it will be peeping out to form the orbital cavity. There will be another bone which is on the back side, and this different parts of the bone are body of the sphenoid, the lesser wing of the sphenoid, and the greater wing of the sphenoid. So please remember these things, because these are not seen directly coming into the view from the front, and these also you will think that these seem to make this topic very hard, but it is actually not. Just have a look at the different bones, and in this animation it was possible because you can see the orbit quite clearly. This is the orbit, right? So I will erase all. This is the orbit, the orbital cavity. It is having an apex. This one is the apex, and this one is the base, and that is why we can see that what might be the bones which might be contributing to the orbital cavity. Okay, so we are not interested more in the orbital cavity bones than just the orbital bones which make up the orbital margin. Okay, going forwards, I will just rotate the structure now. Okay, and I will make the frontal bone visible. So here we can see now, let us go from the roof. In the roof, what we can see now is that, while I am trying to zoom in, wait for a minute. So while I am trying to zoom in, I just see that this roof, it is made up of two bones. Number one, it is the frontal bone, and the second, this is the lesser wing of the sphenoid. Okay, Please do remember that this is the lesser wing of the sphenoid only, because in animation anything may be coming into view, because the whole of the sphenoid bone, it is making up the some parts of the upper margin also, some part of the medial margin also, and some part of the lateral margin also. So I must be making it up clear with the help of this drawing, that please see this. The part which makes up the roof is actually this one. This is the frontal bone, the orbital part of the frontal bone. It is actually frontal bone, and the part which is covering up, making up the orbit, is just called the orbital part, the frontal bone. And just the roof, please try to delineate the roof. Okay, when I am saying the roof, it is meaning these things only up till this structure. So up till this structure, what we are seeing is, it is the lesser wing of the sphenoid. Lesser wing of sphenoid. Okay, so the thing which makes up the roof is actually the frontal bone, the lesser wing of and the lesser wing of the sphenoid. And the moment you see this gap, this is the superior orbital fissure. That means the roof has ended. Okay, so the margin of the roof is up till the, I'll erase it all. So the margin of the roof is constituting up till the upper part, that is the frontal bone. It includes the frontal bone and the lesser wing of the sphenoid. Lesser wing of sphenoid. And the moment you get the fissure, that is the superior orbital fissure, that means you are at the margin of the roof, and this forms the boundary between the roof and the lateral wall. This is the lateral wall. So let us now move at the lateral wall. While we are trying to move at the lateral wall, I will just keep the sphenoid bone inked up. So when we are moving the lateral wall, we can see that it is made up of two bones. One is the zygomatic bone. I will ink it up. This is the zygomatic bone, and this is the greater wing of the sphenoid. Just have, if you have the skull, it is very good. Take a look at the skull. Okay, otherwise it may be confusing, or you just orient yourself, put behind the video, so as to orient yourself if you have missed any part. You might be confused at which one is the greater wing and which one is the lesser wing. Lesser wing is constituting the orbital roof, okay, along with the frontal bone, but the lateral wall of the orbit is made up of the greater wing of the sphenoid and the zygomatic bone. Okay, this is clear that the zygomatic bone and the greater wing of the sphenoid is making up the lateral margin. Once again, put together, I will just move the animation. Okay, when I move the animation, then I see that this is the lesser wing. Okay, please make a mark. This is the lesser wing, and the gap between the lesser wing and the greater wing, it is called as the superior orbital fissure. It is retort shaped. Let me tell you, this structure, it is called as a retort shaped flask. Okay, so in the ancient times in chemistry, they are using one kind of flask which is called as the retort shaped flask. Okay, so this is the diagram they are making it simile with, so as to describe the superior orbital fissure. Okay, now once again going to the one, we have just moved on from the superior roof to the lateral wall. Let us move at the floor. So if you look at the floor, then you find that there is a white gap, and this gap is called as the inferior orbital fissure. Let me ink it up. This is the inferior orbital fissure. So this inferior orbital fissure, this is the gap between which separates actually the lateral wall from the floor. This is the floor. Okay, so this floor, inferior orbital fissure, it is separating the lateral wall from the floor. Okay, and the inferior orbital fissure, what it makes up with, it is making up with the greater wing of the sphenoid. This is the greater wing of sphenoid. If you have not gone through or confused with the sphenoid, then please go through, because it won't help that without knowing the sphenoid you are going to study about the orbit, okay, the orbital cavity. So just go through the greater wing of the sphenoid. So, and the next part which is contributing to this gap or the fissure is the maxilla itself. This is, I mean it down, this is the maxilla bone. Okay, so please have a look. This is the greater wing of the sphenoid and this is the maxilla. Okay, so this floor, it is made up of some part with the, yes, the lateral part. This one is made up with the zygomatic bone. Yes, of course, you are right. And the floor, it is most of it is occupied by the zygomatic bone, maxilla bone, sorry. Less of it by the zygomatic bone and most of it by the maxilla. And of course, some part of it, it is also being formed by the palatine palate. Some part of it is also formed by the lacrimal, and this, of course, it is more of a constituent of the medial wall. But you can, okay, no need, just you go through as you know the floor, it is constituted of the zygomatic bone from the animation. Actually, animation is not so much proper at sometimes, but still it is the zygomatic bone and the maxilla. Okay, now moving on to the medial wall. Lateral wall we have studied. The medial wall is something which you cannot see, and this actually constitutes the most of the bones, because these are the bones which are not so much visible. Yes, of course, I will ink it out. This is the maxilla bone itself, this one part. Up till this part, this is the maxilla. This part, it is the lacrimal bone, as you have already seen. Okay, and some part it is by the body of the sphenoid. Okay, and also by the, I have already told you that the sphenoidal crest, the ethmoid bone, and this is the sphenoid. This some part in between, it will be the ethmoid bone also, and also the palatine shelf. Okay, so all these things, they will be making up the medial wall. So medial wall, just have a look. This is the maxilla. This one is the lacrimal bone they have shown you. But behind that you will see the ethmoid bone also, and in the most posterior part here they are showing the lesser wing, but some part, I will link it out. It is not proper, this is an animation. This part, it is making up the body of the sphenoid. So these things, they make up the medial margin of the orbital cavity. Okay, so let us see what are the things. Once you have, if you are disoriented, please have a fast rewind it, take a look, and then again come back to the same point. Let us see what are the things that, or what are the fissures that two fissures I have already told you, which are present in the orbital cavity. That means what are the bony landmarks that we are going to find in the orbital cavity. The first thing which I have told you, it is the superior orbital fissure. Okay, let me draw it out. This part is the superior orbital fissure. And this part, this is the optic canal. So optic canal, what it does is, it will be directly transmitting the optic nerve along with the ophthalmic artery. Okay, so this optic canal, it is the direct canal through which the innervation or the eyeball, the important optic nerve of the eyeball, it is coming up. Okay, and the margins of the optic canal is, they are saying that it is made up with the anterior and posterior, pillars of the bony crest, which actually join the lesser wing to the body of the sphenoid. So body of the sphenoid, the To the body of the sphenoid, both the greater and the lesser wings are attached, and the lesser wing is attached by two pillars, the anterior and the posterior pillar, and both of them they are forming a canal inside, and that it is called as optic canal, through which the optic nerve and the ophthalmic artery is passing. Okay, so this is done with the part which is visible from this view. Let us take a view from the lowermost part. So in this part you can see that there is an inferior orbital fissure. So let me ink it out once again. This is the inferior orbital fissure. This is the inferior orbital fissure. So in this inferior orbital fissure, you will be also seeing that there is a hole inside. This is the infraorbital groove. Okay, there is a presence of a groove. Do you see? And there is a presence of a foramen also. So infraorbital groove and infraorbital foramen, through which the infraorbital, same name, infraorbital nerves and vessels are passing. Okay, so infraorbital nerve and infraorbital foramen, they are making the passage of the infraorbital nerves and vessels. Now in this part, since this is an animation only, some part may be missing. What is actually missing is there is a tubercle here, there is a check ligament for the lateral rectus muscle also, and because you know there are muscles, I think I need not to tell you that the muscles of the orbit are actually 4 in number primarily. These are first one is lateral rectus, counterpart is medial rectus. That means one is pulling the eye laterally, one is pulling the eye medially. Lateral rectus and medial rectus, then superior rectus and the inferior rectus. Okay, these are, as you think in from your HS part, that one is pulling it upwards and one is pulling it downwards. Okay, so these recti, these are actually coming, all these muscles are coming from the back side, and these muscles, the common originating point is a common tendon, which is called which is actually making up the cavity of the some part of the orbital cavity. So that is called as the common tendinous ring, from which all of the muscles they are making up and they are coming out together. That is called as a common tendinous ring, that is occupying the gap between the greater wing of the sphenoid and the lesser wing of the sphenoid. I think you know what is the space between the greater wing of the sphenoid and the lesser wing of the sphenoid. Yes, it is the superior orbital fissure. So superior orbital fissure, it is a gap between the greater wing of the sphenoid and lesser wing of the sphenoid, and all these muscles, and additionally 2 more plus 1 more levator palpebral superioris. These are 4 plus 2 more, as you already know. This is the superior oblique and inferior oblique, 6 muscles, and the levator palpebral superioris. They are making up together. They are making up the origin from the posterior most part of the orbit, that is almost from the apex. And this common tendon, it is called as the common tendinous ring. Okay, they are making up a circle in the form of a circle, and they are occupying the space of the superior orbital fissure. Okay, so they make up a circle that is called as a common tendinous ring. Okay, now let us go through again what we were talking about. We were left out from there. So this is the inferior orbital fissure, as I was talking about, and from here I was talking that I was telling you that the inferior orbital groove, there is an infraorbital groove which is present here, and there is an infraorbital foramen. From this infraorbital groove and the foramen, the infraorbital vessels and nerves, these are passing. Okay. The next thing which I want to I actually left out was this was the lateral part. So in the lateral part there is a check ligament I was telling, and this check ligament is called as the Whitnall's tubercle. So I switched on to the recti muscles because I was telling about the Whitnall's tubercle, and the Whitnall's tubercle, it is actually providing the check ligament for the lateral rectus muscle, and also to the the ring which is actually providing. We'll come to that. The tendinous part of the ring which is actually holding the eyeball, and it is also providing the mobility to the eyeball. Okay, so please remember this Wittnau's tubercle. It is actually present in the lateral wall as a part of, as a small spinous projection. Okay, please remember this. It is not shown in this animation because this is animation which is incomplete. That is why all animations are incomplete. It cannot be compared with the diagrams of the atlas. Okay, moving forward, I am just using it so that it becomes easier for you to understand. So what we see in the above is that there is a space in the, I'll ink it out, there is a space somewhere here in which the nasolacrimal duct, not this one, this is actually the presence of a tendinous ring. There is a small projection here. In this, the inside you will see a cavity. This is a lacrimal groove. In this lacrimal groove you will find actually there is a lodgement, there is a space for the lodgement of the lacrimal gland. Okay, lacrimal gland, it is releasing its secretions and it is going through this entire eyeball to the surface of the eyeball to finally to come out through the nasolacrimal duct to the inferiormost meatus, that is the inferior meatus in the form of the nasolacrimal duct. Okay, so there is a nasolacrimal sac, there is a nasolacrimal duct, and finally it is opening up into the inferior meatus. So this lacrimal groove, it is lodging the lacrimal gland, and there is also a presence of a small bony tubercles. This is actually groove, supraorbital groove, through which the supraorbital vessels and nerves are passing, and also there is a spinous projection through which the superior oblique muscle, it is coming out from here and it is making its attachment. We will see in the diagrams further, and this is a formation of a trochlea. So there is a spinous process for the lodgement or for the attachment of the trochlea. So this is a trochlear groove. Okay, so that the superior oblique muscles can, which of course is originating, as I have already told you, all the muscles, external ocular muscles which are providing the movement to the eyeball, they are coming out from the common ring. Okay, so common tendinous ring which is present. That common tendinous ring is a form of a O or 0. Okay, it is a circular shape which is occupying the area in the superior orbital fissure. So of course superior oblique muscle is also coming from there, the same thing, but it is making a turn so that the force of movement is, or the force of contraction is, it is not similar to the superior rectus muscle, and in fact it makes an intorsion while it is doing its activity. That means winding the from the front, if you are looking, then it will be making a clockwise turn towards this side, is because of the superior oblique muscle. So this movement, which is, although the muscle is attached to the back side in the common tendinous ring, but it can make an intorsion movement because of the forces of contraction being changed from one direction to the other, is by the presence of this trochlea. Okay, and this is the trochlear groove in which the tendon is being lodged. Okay, so now these are the things which I have told you are present in the roof. Okay, let's move downwards. There are nothing as such present, but one thing I want to tell you is that from this side you can see that the superior orbital and the infraorbital groove, they make up a shape of a V. Okay, can you realize that from this diagram? Yes, they are making up a form of a V. And one more thing, please remember that this supraorbital groove, what it is doing is, I will just show it from above. Just please have a look. This is the supraorbital groove I was telling about. Okay, I will link it out. This is the supraorbital groove, this one. Please make it a point that this is actually what it is doing. Which part of the cavity it is? It is a direct, this part when you are seeing this supraorbital groove, this is actually a communication of the orbital cavity with the middle cranial fossa. You can make out, right? So this middle cranial fossa, that is the middle cranial fossa maximally, it is being made up by this greater wing of the sphenoid, this one. But this lesser wing and the greater wing, between them you will see the supraorbital groove through which the different constituents are coming up and they are innervating the different muscles which are extraocular muscles and also the surrounding structures, the glands and whatever things are there. So these are coming out from the middle cranial cavity. Okay, so it is a communication with the middle cranial cavity. Once again, when we look from the front side, then we will see that there is an infraorbital groove also. Does it communicate with the brain or cranial cavity? Just please have a look. From behind, we could see that there is a cavity. This is the supraorbital cavity. This supraorbital cavity, it was communicating with the cranial cavity. That means it is communicating with the brain. That is why nerves and vessels are growing from here. But where is the infraorbital groove? Is it somewhere here? No, it is not here. It is actually present from the inferior surface. So while in the inferior surface, you can see from here, I will mark it out. This is the infraorbital cavity. Okay, do you see? So infraorbital cavity, just please keep a close attention to this particular groove which I am showing you while I am moving the entire animation. That this is communicating, this one, okay, and this is communicating with the orbital cavity. So what is this space? This space is the pterygopalatine fossa as well as the infratemporal fossa. So just medial to this part, the one which I am showing you here, this is the pterygopalatine fossa, and this part just behind the bone, this one, this is the infratemporal fossa. That means this fossa is below the temporal bone. Okay, let's again take a closer look. I will zoom in. So if I just move this animation from below, then what I see is this is the infraorbital groove, and this part it is actually communicating with the infratemporal. This is the temporal bone, right? So this is the sphenoid bone. This is the temporal bone. This temporal bone, below this is the infratemporal fossa, this entire part, and just in front of the pterygoid processes, this is the pterygopalatine fossa. Okay, so this is the cavity basically it is dealing with from the infraorbital fissure. Okay, that is why the pterygopalatine nerves and vessels, these are traveling from the back side, and this may be innervating, or these may be traveling through the orbit through this cavity, pterygopalatine nerves and vessels. Okay, now just moving forward, we have seen the boundaries, we have seen the different bony prominences or the bony cavities which are present in the orbit. Just please take a look at the different contents. Okay, so this, in the content part, you can see directly that there is the eyeball and the extraocular muscles and certain vessels they have been delineated. Okay, so what I will do is I will zoom a little bit in. Zoom in a little bit. And what I will do is I will just remove this eyeball. So what we see is, in in the eyeball, if I just pull it a little bit downwards, okay, from this view, if you take a look, then what you see is this part from where I will link it out. This part, when you see, this part is actually the part which is called as the common tendinous string. Okay, so in this common tendinous string, we are seeing the origin of the different muscles, extraocular muscles of the eyeball. So what do we see? Let us name the muscles. It is already here. This one is called as the superior oblique muscle, and the superior oblique muscle, it is actually, what it is doing is, it is forming a direct, if you see a little bit zooming out, so you can see that it is forming a pulley or a trochlea in by attaching, holding on to the surface of the greater wing of the lesser wing of the sphenoid. Okay, so with the lesser wing of the sphenoid, it is making a pulley kind of, it is making a kind of turn, so that the forces of movement is being diverted from directly backward force, so that the eyeball is elevated, to the form of a intorsion, which will make the eyeball move in a clockwise pattern. Okay, then please take a look at the counterpart muscle. I will zoom it again. Please take a look at the counterpart muscle. This is called as the inferior oblique muscle. So inferior oblique muscle, while this muscle, let me tell you the movements also, because this muscle will act, it will contract in this direction, and this will make the eyeball, this is the eyeball, to move in a clockwise direction. Okay, right? You agree with me? Now if I just erase it all, and I consider the movement of this inferior oblique muscle, which is attached to the floor, that is the maxilla bone, then it will make a contraction and make the eyeball move in a different direction. What will be the direction? It will be the anti-clockwise direction movement of the eyeball, that is extorsion, that is moving in the anti-clockwise direction. Okay, then what the other muscles are doing, this is called as the superior rectus muscle, and it will make the eye elevated. This is the inferior rectus muscle. Okay, and it will make the eye depressed. If this muscle will make the eye look down, this muscle will make the eye look up. Okay, so all these muscles are acting in different directions, they are arranged in different directions, so as to make the movements of the eyeball. Now one thing, two more muscles which are left behind, the extraocular muscles which make the movement of the eyeball. This is the lateral rectus, which will make the pull in this direction, and this is the medial rectus, which is in this view it is not so much visible, which will make the movement in this direction. One thing I want to tell you, that this arrangement of these two muscles is in the same transverse plane. Do you see that? This is exactly horizontal. So what makes the movement of the lateral, what the lateral rectus is making the movement in the eyeball? It makes a lateral movement of the eyeball. The eyeball will look laterally towards the sides, okay, towards the lateral side, and when the medial rectus is moving, it will simply make the eyeball move medially, okay, in this direction. So they act in synchrony. While the right eye, for the right eye, suppose I will erase it. For the right eye, if the eyeball has to be moved in this direction towards the right side, you want to see the right side of your of the entire area of your vision. You want to have a glance on the right side. When you are looking at the right side, then the lateral rectus of the right is acting and the medial rectus of the left is acting. So they act in synchronous way. Okay, one muscle of the other with the counterpart muscle of the other part, so that you move, both the eyeballs move in the same direction. You can have the glance of that particular part field of vision clearly. Okay. So while the lateral rectus is moving in this direction, the medial rectus of the left eye is moving, so that both the eyes are looking in the same direction. It is not that you just want to see the lateral part and your right eye is moving because of the activity of the lateral rectus, and your left eye, the medial rectus, is not cooperating. It has to cooperate. In the normal physiology, it cooperates and it allows both the eyes to move in the right direction. While if the opposite thing is happening, that means the lateral rectus of the left eye is moving, then the medial rectus of the right eye will have to cooperate, so that both the eyes are looking in the left direction. Okay. This two muscles are in the same plane. Once again, I am telling you, this is in the same plane, the same horizontal plane of vision. Both the muscles are attached in the same plane. Okay. But for the other muscles, if you consider for this muscle, the superior oblique and the inferior oblique, you can see that in their direction from the common ring is at an angle from the sagittal plane. So if I tell you that this one is the sagittal plane and this is the angle, then the angle you measure, it is actually 25 degree. Okay. So what I want to tell you is that, I'll just zoom it out. And I will have a look from above. Okay. I will just fade this one, so as I look into the muscles more clearly. Okay. So what I want to tell you is that I link it out. Please have a look. This is the superior rectus muscle. This is the superior rectus. And this superior rectus muscle, what it is doing to the sagittal plane, this is the sagittal plane, it is making an angle of 25 degrees. 25 degrees. So that is why I want to insist this point is that when it is acting, it will not just simply make your eyeball look up. Had that been that it is parallel to the sagittal plane, then the eyeball would have moved simply up. But since it is acting at an angle, then it makes the eyeball move up as well as a little bit deviated towards the laterally. Okay, so there will be a lateral rotation, lateral deviation also. There will be no doubt there will be a upward deviation, so that the eyeball looks up. There will be a little bit movement towards the lateral side, since the angulation is at 25 degrees. Just imagine, and there will be also a little bit of extortion. So there is a conjugate of movements which is happening just because of this angulation. And the same thing, this is 25 degrees I have told you. Okay, I will link it out so that it becomes easier. So this is 25 degrees. The same thing, 25 degrees. The same thing in case of the oblique muscles. If you see, this is the superior oblique and inferior oblique. Both of them are one on the superior part and one on the inferior part. Both are parallel, no doubt, but they are making an angle of 51 or 50 degrees, 51 degrees with the sagittal plane. So please just have a idea of why these conjugate of movements are happening. It is not like superior oblique muscle is acting and just it is making an intorsion, extorsion simply and just it. No, there is a conjugate of things happening because these muscles are attached at angulations. It is not simple that like the medial and the lateral recti, these are attached to the eyeball at a simple horizontal plane, so that the action of the muscle will make it move the eyeball towards it in a simple horizontal, just like the medial and lateral rectus in the simple horizontal plane. The upward movement, lower movement, the move a little bit gaze towards the nasal side in inferior quadrant, inferomedial quadrant, superolateral quadrant. These movements are possible because these other muscles are not in a simple sagittal plane or simple horizontal plane. So this vision is not just simply looking up, looking down, looking right side, looking left side. Okay, it is you can see a quadrant which is placed between moving up, looking up and looking towards the right. That is the superolateral quadrant. This is possible because of the conjugate of movements. So it is not just simply one muscle which is acting, except the movement of looking towards the right or looking towards the left. Except that the other movements of the eyeball is a conjugate of the muscles, the activity of muscles, which goes together so that you have a complete view of the things which are present in front of you. Okay, so moving forward. So I will make this show again and let me move it towards the front. Okay, so what I was telling about, or I was about to tell, was one more thing, that when you see this ring, this is the common tendinous ring. This common tendinous ring, it is having this common tendinous ring. This ring, this circle of ring, it is dividing the superior orbital fissure into 3 compartments. Number 1 compartment, number 2 compartment which is inside the ring itself, and number 3 compartment which is medial to the ring. Just remember one thing in a pointwise fashion, that this number 3 compartment will be passing on only the infraorbital vein. Inferior orbital vein. And the counterpart of it is, since there is an inferior orbital vein, the superior orbital vein is from this part. Okay, superior orbital vein. So by now, if you do not know, just I want to tell you that the extraocular muscles, all the extraocular muscles are supplied by the oculomotor nerve. Okay, so the oculomotor nerve, it is coming just in the substance in the ring itself. So the oculomotor nerve is occupying the second compartment. By this I mean that, by the second compartment I mean that it is contained within the ring itself. Okay, and the muscle except, okay, there is a thing which is called as except, all the extraocular muscle of the eyeball are supplied by the oculomotor nerve except superior oblique, which is supplied by the trochlear nerve SO4, and lateral rectus muscle, which is supplied by the abducens nerve, okay, LR6. Okay, so the 6th cranial nerve, it is traveling in this ring itself, and the trochlear nerve, it is there outside. In the outside, of course, you will see few more nerves which are coming, one for the lacrimal nerve, one will be the nasociliary nerve. So these are for the nearby structures. Since the lateral rectus is very lateral, and since it is easier for the for innervating the I mean to say that since it is occupying the lateral most part, it is being innervated by the 6th cranial nerve, and the superior oblique muscle, it is supplied by the trochlear nerve. So please remember this thing, that superior oblique muscle, 4th cranial nerve, lateral rectus muscle, 6th cranial nerve, except that all are supplied by the oculomotor nerve. So while I am explaining this common tendinous ring, I have also compartmentalized this entire thing, which is the superior orbital fissure, which is also called as a retort shaped flask, into 3 compartments, 1, 2 and 3. The 1 and 2 is having common difference, that one is containing the superior orbital vein and the third one is the medial most compartment is containing the inferior orbital vein, and the nasociliary nerve or the nasolacrimal nerve, these are, since it is near to the lateral most compartment, so these nerves are going on through that. And in the middle one, it is occupied by the oculomotor nerve and also the sixth cranial nerve. Okay, so all these things, these are making the constituents. Yes, of course there are 2-3 more constituents also, just go through the text by yourself. Moving on to the next part. When I zoom out, I just want to show you one thing, that in the lateral part I had shown a tubercle. I'll link it out. So in this part there is a formation of a tubercle which actually holds the Wittnau's, which is called as the Wittnau's tubercle. It is acting as a check ligament for the lateral rectus. So did you see that lateral rectus? So this lateral rectus is having a check ligament here, which is called as in the point, which forms a point in the tubercle in the body of the sphenoid bone, okay, zygomatic bone. So this is called as a Wittnau's tubercle. And on the medial part also, in the posterior lacrimal crest. So lacrimal bone has got an anterior and a posterior lacrimal crest. In the posterior crest there is another check ligament for the, you can say, the medial rectus also. So both the recti are having check ligaments on the medial and the lateral parts, and this actually forms a ligamentous projection which holds the eyeball in its place. This is the eyeball, and this two check ligaments, these are holding the eyeball in its place with the help of a ligament which is enclosing the inferior, what you can see here, yes, this is inferior rectus muscle and inferior oblique muscle. It is also enclosing, and this thing, it is called as the Wittnau's ligament of Lockwood. Okay, this is the Lockwood's ligament, which is actually holding the eyeball properly, and this allows the free movement of the eyeball. So important thing here I have missed out, what I have missed out is that you know that the eye is actually an extension of the neural tissue. If you do not know, then you just go through. Actually the eye is actually the projection of the neural tissue. So since it is a projection of the neural tissue, it will have also the enclosures of the neural tissue as it is there in the brain. So what do we have? The coverings of the brain. Yes, the coverings of the brain are dura, arachnoid and pia mater. So in this part, in the attachments of the eyeball, I am more concerned about the dura mater. What the dura mater will do, the dura mater along with the optic nerve will come, and in the posteriormost pole it will just separate into two sheets. One sheet will directly go into the, and it will attach to this part. This is the periosteum. One sheet will directly enclosed, it will be enclosed in the periosteum. It will be very much intimately adherent to the periosteum as well as to the orbital margins also, and it will provide orbital septum. There is something called as the orbital septum. So orbital septum is the dural extension which is actually very close to the periosteum, and it is going to the eyelids also. So it is providing attachment to the eyelids also. Okay. This is the outer layer of the dura mater, as you have the inner layer and outer layer of dura mater in the brain. So the outer layer which is coming along with the optic nerve, it will be extending and it will be attaching to the outer surface of the orbit, the periosteum, and the inner layer, it will be coming around at the sclerocorneal, at around the equator and the sclerocorneal junction. It will be providing ligamentous attachment to the Wittnau's tubercle. This is the Wittnau's tubercle, and also to the posterior crest or posterior groove, the posterior crest, of the lacrimal bone. that means the posterior pillar or posterior elevation of the lacrimal bone itself, and this is the medial, you can say this is the medial tubercle in which the medial rectus muscle is having its attachment. So here the inner layer of the dura mater will be providing a kind of fascial attachment, and it will be enclosing the inferior rectus muscle also and inferior oblique muscle also in it, since it is occupying the lowermost areas, and it will provide a ring. This is the Lockwood's ligament, which will hold the eyeball and it will prevent the eyeball from falling backwards. It is not that when you are looking up suddenly your eyeball has fallen back. Of course periorbital fat is there, but there is also presence of this attachment which is not allowing the orbit to fall back. Okay, so the constituents are all these muscles of the orbit that I have told you, the nerves, the periorbital fat. Yes, of course, one thing I have forgotten to tell you, this periorbital fat, this is no need to tell, in fact you can guess it, that periorbital fat will be occupying the area between these two layers of the dura mater that I have just discussed, right? One is attaching to the periosteum, the other is attaching to the eyeball proper at the sclerocorneal, just behind the sclerocorneal junction. So this area between these two, it is occupied by the periorbital fat. This is also important, because in a very cachectic person, when he has lost his weight, so just imagine some person in the Hitler's concentration camp. Just imagine the persons which you see, the photographs, they have shrunken eyeballs. So periorbital fat is also important because this has to be occupied by the the stuffing matter. Fat is like a stuffing matter, so that the eyeball is protruding out and it is also filling up the space. Okay, so all these muscles and all these nerves which I have discussed, these are occupying, these are the contents of the orbit. Okay, so now we can go to the next part, that is the applied importance of this part. In the applied importance, there is a presence of preseptal cellulitis and orbital cellulitis. Cellulitis means inflammation. So in the orbit, if there is a microbial invasion or by means of any other infections, when there is a presence of inflammation in the orbit, in and around the orbit, this will lead to cellulitis, or the scientific term of cellulitis, the common man's term is inflammation or the infection. So lipodermoid is another orbital tumor which is present in the eyeball. So in this picture you can clearly make out that there is an orbital tumor which is found in this part. Okay, so this orbital tumor is actually which will make some kind of symptoms like the eyeball will be popping out. So this orbital tumor, this is lipoid, that means some fat material is there. So this lipodermoid is the presence of fat in the eyeball. Okay, making this is the second most cancer which is present in the children. This is called as rhabdomyosarcoma. Please take a note, please remember, because this is asked in the MCQs. That is highly malignant extraocular muscle tumor, and this is called as rhabdomyosarcoma. Sarcoma means tumor of the muscle. So extraocular muscle tumor, this is rhabdomyosarcoma. So in case of blow which is actually affecting the lateral parts, you may have a fracture of the maxilla bone, and then the contents, the periorbital fat may come down, and so you have a shrunken eyeball. Okay, so this is the diagram, beautiful diagrammatic representation of the eyeball. And with this I complete the topic of orbit and its contents. I have described the boundaries also. Okay, I think you have felt the class very much knowledgeable, and if you have any concept doubts or any explanations which were improper, then you please discuss with me. Thank you.